I met with actually on 2 occasions. It was supposed to be 3, but it did not work out that way.
So 2 occasions, but 3 sessions?
Basically, yes.
Okay. And where were you, where did you meet with Tanner?
I met with Tanner at a private interview room near the pod where he's incarcerated. We had privacy. The door was shut. The chairs were comfortable. It was, for a jail setting, very conducive to having a private, interview with any defendant. We could hear each other, see each other. It was fine.
Right away, this testimony is setting up something critical: privacy. In forensic evaluations, the room itself can become evidence. If someone can't speak freely, the accuracy of everything that follows gets questioned. And think about it. How honest would you be if someone was listening outside the door?
Why is that important?
Because when you are trying to interview a defendant through glass or through one of those telephones, you really cannot get into the intimacy and depths of their life. You cannot do that through a telephone or through a glass barrier. It is a relationship. When I meet with someone like Tanner, we have to be able to see and hear each other, to actually be in the physical presence of each other, because it is not just an interview for facts. It's my ability to develop a relationship with Tanner or another defendant, and in that relationship, understand how he functions. It's one more very, very important piece of evidence.
Could the fact that there were other people, let me back up and rephrase this. How would the presence of other people in the room outside of the team, how could that affect the validity or the rapport building?
I'm not sure I'm understanding. I mean, we spoke privately. There were guards outside, but they could not see in the room.
Would having the guards inside the room impede your ability to conduct a thorough evaluation?
I would not have conducted an evaluation under those circumstances. There would be no way that private information, not just from a legal perspective, but very sensitive information.
That's a major legal point. The witness is saying he wouldn't even conduct the evaluation under those conditions. Translation: if confidentiality is compromised, the defense can argue the process was fundamentally flawed. This isn't just comfort, it's credibility.
No defendant would ever, especially in an incarceration setting, divulge issues of vulnerability or loss or weakness or anything. So I would have probably asked you to find a court order that a guard should not be in there, because I could not conduct an evaluation like that.
How important is it, you mentioned the word rapport, so how important is it to build rapport with the person you're evaluating?
Well, I think it's important to define the word rapport. My job in this is not to become friends with Tanner. My job is to set up an ambiance, an environment where Tanner or other defendants will feel comfortable talking, which means that I try to make it clear that they are accepted by me, that I have a lot of experience, that I'm not here to be criticized or judged, but I'm here to fully be a listening ear to understand. And that, yes, I may ask questions that are going to be painful, that are going to be embarrassing, but I'm hoping that there'll be a level of trust and actual likability between us, that a client or a defendant would divulge such information.
During these evaluations and these interviews that you do, how important is it to get that personal information from the client?
It's crucial. I mean, if you went to a therapist and you did not feel comfortable with that therapist, you would not divulge your information that is highly personal. You would not feel comfortable with that person. There's a big difference, and I get asked this question a lot, between caring and likability.
Now the case pivots. We're moving from interview conditions to child development, and that usually means mitigation. In court, this kind of testimony often aims to explain how someone became who they are, not excuse what happened. Big difference, and juries notice it.
And respect. Okay, I want this to be a respectful relationship. It's fine to tell some jokes sometime, and Tanner sometimes says things that are a little bit off the wall, and that was fine, but it has to be a level of trust. And that it's not a therapeutic relationship. I'm a forensic psychologist, but it has to be that he knows that I am listening and that I will ask questions that will allow him to tell the whole story about himself.
Is that another reason why it's important to have your privacy and not have other people in the room with you while conducting these evaluations?
Absolutely.
Dr. Brahms, let's talk about child development, because that's why we're here, what you were retained to talk about. When we talk about, and when we use the phrase child development, what do we mean by that?
What we're talking about is the trajectory of someone's life. We're talking about what happens, first of all, in the womb, in utero, which obviously is very significant in this case, but also historically. What are the people like that raised a particular person? What histories do they have? Obviously, in this case, both his mother and grandmother had problematic histories. Doesn't make them bad people, but they do. And then we look at stages of development. Every child, whether you live in Fort Worth or you live in, West Africa, goes through similar stages of child development, of where there's certain milestones and certain critical stages of life that children have to go through, hopefully successfully. And then we look at adult outcome and what skills and strengths they had or did not have as a child to have a successful adult outcome. So development is looking at the whole course of someone's life and trying to understand at every point why things were either successful or why they might have been problematic.
You had mentioned in utero. Does that mean that development begins before birth?
Well, it begins genetically as well, but yes, significant issues can occur when there are prenatal complications.
Dr. Brahms, you talked about there being stages of child development. Let's talk about those stages, okay?
That's fine.
What is the first stage of child development?
Well, the first thing a child has to do is they have to be able to attach to others. And in order to attach to others, you have to have a caregiver that is there for them on a consistent basis. It doesn't mean they have to be perfect parents. None of us are perfect people. But it means that they have to respond to that child's needs. It's reciprocity. It is the give and take between a parent and child. And in order to do that, you have to have a parent that is emotionally and psychologically available without their own problems to actually respond to what a child needs. And it's very simple.
This is one of the strongest moments so far. The world will respond to them. That's the foundation being described here. When those early needs aren't met, experts argue the effects can echo for years. Do you think childhood environment should weigh heavily in sentencing decisions?
A mother needs to be able to touch the child's face, and then the child touches the mother's face. The mother smiles at the child smiles back at the mother. But to do that, you have to be consistent, and you have to have the ability and knowledge to do that to an infant. When those things do not happen, with a regular child, not somebody who has a neurodevelopmental disability, when that doesn't happen, the child becomes very agitated. They cry a lot. They scream, because the parent is not there to modulate their emotions. When an infant knows that there's a caregiver and the world will respond, the purpose of parenting in those first year is to teach a child that the world will respond to them and that they don't have to go to desperate measures to get the world to respond to them, that world will be responsive. So that first period of attachment is significant as a building block for the rest of someone's life.
Dr. Brahms, you mentioned neurodevelopmental disorders. How can a neurodevelopmental disorder affect the development of a child?
Well, profoundly. I mean, I know back in the mid-'70s I was doing research on how children who were not, we call it biobehaviorally regulated, how that affects not just attachment, but it also affects the rest of their development in their life. So when we have a neurodevelopmental disability, one of the impairments is the ability to self-regulate. Now, Ms. Anderson, in the olden days, okay, even more olden days than me, okay, you were able to do evaluations on infants, and they had a pinprick of experiment where you take newborns and you prick their heel just a little bit with a little needle. Some children didn't even notice it. Some children cried, but then they put their hand in their mouth and self-soothe. Soothing is not something that people with neurodevelopmental disabilities do. Tanner has never self-soothed except in very immature ways. Some children will just cry and cry and cry. So much of this is related to, some of it's we call temperament, but a lot of it is just basically brain development. So it does matter, because a child who is neurologically impaired is going to have a harder time when that comfort and that reciprocity is not there because they can't comfort themselves.
So how important is it to, well, let me ask this. Are interventions available for children?
Oh, absolutely.
How important is it to have an intervention as quickly as possible or as soon as possible?
Well, I don't want to be unpolite, but it's not an intervention. It's a course of interventions. It's a multimodal intervention. So first of all, the timing is extremely important. It is important to start as soon as you see developmental differences or behavioral differences in a child. In many states, most states, there are infant programs where people come into the house, professionals come into the house and educate the caregivers about how to set up the best possible environment for that child.
Listen to the phrase, everything snowballs. That's the prosecution defense battlefield in one sentence. One side may hear explanation, the other may hear excuse, but the witness is framing development as cumulative, small missed interventions turning into major adult consequences.
But what we do know in terms of early intervention with neurological disabilities, neurodevelopmental disabilities, that if there is not intensive intervention by about age 6, that child is far behind the 8 ball. That the types of skills, attention, self-regulation, socialization, attending to the environment, all of those issues need to be addressed well before a child starts to go into stages of development where those skills are absolutely mandatory. So if you do not have intervention early, and that would be occupational therapy, counseling for the parents or parent guidance, educational issues, there's a lot of interventions. If you don't have that early on, everything snowballs because that child doesn't have the basic, we used to call it learning to learn skills. The skills that you have to learn in this world, to acquire information, to control your behavior, all of those things. If you don't have that by a certain time, your adaptation and your coping skills are going to be ineffective.
You mentioned the term multimodal. What does that mean?
Well, it's a fancy word, but what multimodal means is that you have interventions not just in one area, but in many areas, because neurodevelopmental issues are pervasive. And what we mean by pervasive, it's not just a learning disability. You know, I have friends who actually became attorneys and doctors, and they had a learning disability, and they got reading help, or they got whatever they needed, and they went on with their lives. And some of them they listen to audiobooks now because they don't like to read that much, but they still become lawyers or doctors. That's a learning disability. What we're talking about, and I know this jury has heard this forever, but we're talking about deficits that are pervasive. They're in the frontal lobe. They're in the limbic system. They affect the way that somebody perceives and interacts with the world. So there's language deficits. There are occupational deficits in terms of learning to learn, learning how to pay attention in school, getting other skills, whether that's baseball or handwriting. And then, of course, a very important core is the parenting issue. Those parents, because the people who really intervene emotionally as well as functionally, like teaching children, are the parents. And they are probably as important or more important than any of the other interventions that are available.
You mentioned occupational, you mentioned learning disabilities, you mentioned teachers. What other kinds of interventions are available for children with neurodevelopmental disorders?
Well, there's psychiatric interventions. There's always the option of medication. And this is an important issue because, number one, a majority of children with neurodevelopmental issues have, in quotes, ADHD. They do not pay attention. They are impulsive. It's all of that. You know, we can use whatever diagnostic terms we want to use. I usually don't say ADHD because I think it's part of the whole neurodevelopmental issue, but they have those problems. And you can treat that with a wide variety of medications. The secondary problem comes is that children who live a life with this type of impairment develop secondary diagnoses like depression. That's certainly true for Tanner. So we have to look very carefully at controlling those, or at least remediating, addressing those secondary diagnoses. Because then when you have a neurodevelopmental disability or impairment on top of a secondary problem that's major, Now the problem, it's not just additive, it's interactive.
What do you mean by not just additive, but interactive?
Because what happens with this group of neurodiverse people, especially those, here comes another clinical term that we call level 1, higher functioning people, people with a normal IQ like Tanner, is they tend to get overlooked. And what happens is they're oddities. They're oddities in their family, they're oddities in the world, and they develop secondary diagnoses like depression. And then the more depressed they get, the less they function well in other areas. And when they function less well, then they become more depressed. They turn to drugs sometimes. Substance abuse is common in this population, especially these higher level functioning people, because they are not out there. Everyone expects things from them that they can't do. And so they try to mimic what they can do, but they can't do it, and everything snowballs. And so these are serious issues, both in terms of medication and other interventions.
Dr. Brahms, I want to take you back to the stages of development. You had mentioned attachment. Is that the phase also where children start learning how to explore the world around them?
Yes, after a child hopefully becomes healthily attached to the world, there's a stage we call autonomy. And autonomy is, anybody who's had a toddler is going to understand autonomy. You don't need a lecture about this. Children, let's say 3 years old, 4 years old, young, toddlers, a little bit above, will go out to the world and explore. And who do they come back to? They come back to their mommy or daddy. And their mommy and daddy tells them how to explore the world safely. If you want to look at a flower, you go look at a flower in the garden, but you don't rip it up. And you get compliments from your mom. You went and smelled that flower, but you didn't take that flower out of the ground. That is really grown up on your part. And then the child comes back to the parent for that compliment, and they get a hug, then they try to explore something else. So in that stage of autonomy, which is sort of toddlerhood, preschool, they start to learn how to deal with the world with their emotions being controlled and with their behavior being controlled, because there's a solid parental figure, a solid caregiving figure who is there to guide their behavior and give them that feedback and that reinforcement and that guidance, so when they go out to the world, their behavior is controlled, they can look at their environment, they can enjoy their environment, and they get attention. And I don't mean spoiled attention, but they get attention from a caregiver that they are able to be the big boy or big girl and do what has to be done to start to be part of this larger world around us.
What happens if you don't have that kind of solid parent to help you during this stage?
And what happens if you also have a neurodevelopmental disability? I mean, those things are going together in this case. What happens is children who do not have that guidance do not know really how to control themselves. Children who are neurodevelopmentally more normal may have less trouble doing those things. But when you have this hyperactivity and this impulsiveness and this generally agitated state, and when you have a family who can't give you what they need, then your ability to be able to go out in the world and act in an appropriate manner and not be afraid or not be overly inappropriate.
And just as the testimony reaches a key theme, stability, predictability, responsiveness, the court breaks. That timing matters. Jurors now leave with those 3 words fresh in their minds. Sometimes a recess can be as strategic as a closing argument.
That is compromised.
And so in cases where you have a solid parental figure that can help navigate that aspect of child development, is it easier for a child with neurodevelopmental disorders or issues to succeed?
Well, let me phrase that the opposite way. Is that when a child with neurodevelopmental differences does not have steadiness, when they're moving all the time, for example, if their parent is on drugs a lot, if there's different people in the house, if they have different caregivers, they are getting the opposite of what they need, because a child with these disabilities needs predictability and stability and responsiveness. So predictability, stability, responsiveness. That is what is going to modify their neurological damage. Now, all children need that, Ms. Anderson. I'm not saying that we should let other children just do what they want, but in terms of of pervasive developmental issues, it's very important to have that stability, that predictability, and that responsiveness. If you don't have that, the brain does not have a way to modify. I'm not saying heal. I'm saying to modify and have that child have the ability to use all of their ability and their skills to have a more adequate adjustment and successful adjustment.
Hang on just a minute. We have a juror who has requested to take a short break, so let's take 10 minutes and we'll come right back in, okay?